Thank you so much for the great introduction. Thank you everybody who joined in person and over Zoom. Let me... yeah, so basically, as Roberto mentioned, so I have mostly worked in medical image computing, so in medical data. Right now, I work in a lab in Stanford Radiology where we monitor commercially available tools for radiology that do, say, detection of intracranial hemorrhage, pulmonary embolism, and other medical findings. So most of the work that I have done has been with medical data. Starting next year, I will actually be starting my research group in Vienna, in the Medical University of Vienna, where I will continue the line of machine learning for medicine. And there are a few challenges that we have in this domain. Oh, sorry, I will lower this a little bit because I'm a bit short. There we go. Perfect. So there are a few particular challenges that we have when we want to use deep learning algorithms in medicine, related to privacy constraints, the amount of data that we have, etc. So having enough data has for us been a huge challenge always. Like you can imagine that we have, say, CTs, MRIs with very big resolutions, like say 512 times 512 times 200. And we may only have something like 200 samples to 500 samples maybe in a data set. Oh, thank you. I was thinking there is something a little bit unusual here. Thank you so much. So yeah, basically having enough data has always been a big challenge for us. Now, something that really drove the community forward were a lot of open challenge initiatives. So basically challenges where teams could present, could upload their algorithms. And for doing these challenges, there were a lot of data sets that were gathered and released for this purpose. There are a lot of consortia as well that do federated learning. So basically that means updating the model from multiple different institutions at once without having to ever share the data, which is a big problem for us. And of course, we have seen in the last few years a lot of advances in multimodal deep learning, cross-modal attention mechanisms that allow us to adapt to align different modalities of the data and also to use data in an unsupervised fashion without labels. There were also improvements in shared representation learning. And then, of course, we have a lot of advances on foundation models that allow us to perform better on downstream tasks without having annotations, which are very expensive. If you're asking like radiologists to, say, segment certain lesions or tumors, that's a very expensive and time costly process. So we want to avoid that. So there have been all of these advances. However, we still see that sort of the results that are presented in research papers rarely translate to the open world. For instance, there was this very popular example of this system from Google Health for diagnosing diabetic retinopathy, which seemed to work very well on their in-distribution results. But then when they tried to actually use this system in a large-scale study, it proved more troublesome to use it than it was actually helpful, just because the images that were acquired in these real settings were very different from the training data. So then the system couldn't really work. Then also during the COVID pandemic, we saw there were many solutions that came out for saying segmenting lesions automatically, doing triage of which patients had to go to the ICU, etc. But really very few were actually implemented in clinics. So there were a lot of resources that were invested into developing these solutions, and this didn't really translate into a benefit for the healthcare system. Now, even if we look at the devices that have been commercially approved, say, that have received clearance from the FDA or a CE marking in the European market, even when we're looking at those, we see that only a small portion have actually been tested prospectively, the majority only based results on retrospective studies. We also see that there are very certain evaluations on multiple institutions, and also a lot of these results are not really shared. So a big question that we have is, okay, how can we actually then trust these systems? And especially how can we trust them when we see that there are all of these changes going on in the domain? So that results in the issue that most of the systems that we see that are actually used in hospitals target very, very common conditions, such as detection of vessel occlusion, or just very, very common problems that can basically, for which gathering data is feasible. And this is despite the fact that we could actually get like a really alleviation of the healthcare system if we were to use deep learning more effectively. So how can we bridge this? And this is why I think this is, I suppose this is maybe what they invited me, because medicine is one of these aspects where you see that open world learning and anomaly detection could really do the change between these systems actually being helpful or not. So what am I going to talk about today? First, I'm going to talk about what are really drifts that we have in medical imaging. I'm also going to talk about how we can learn dynamically or continuously despite these shifts, and also how we can, in fact, monitor these models in the open clinical world. So you may be familiar with some of these shifts. I assume most of the people attending this workshop are familiar with these general concepts. So we have, for instance, covariate shifts. So this is when, say, the images change, and this happens in our case when, for instance, there is a shift in the patient demographics, or also when there is a change in the scanner used for acquiring these images. We also have label shifts, which can happen when there is a difference on how the experts annotate the data, but can also happen, for instance, when there is a change in the prevalence of a certain condition, or also the rating criteria that are used for that. And then we have also concept shift. So this happens when, say, the actual problem changes because the diagnostic criteria changes over time. And this, for instance, we saw during COVID, like how whether it was possible to diagnose whether a patient had COVID from a radiograph versus some other kind of pneumonia changed during the pandemic period. So I worked a lot in this problem during the COVID time. As I was saying, there were a lot of initiatives to trying to develop these solutions. So we wanted to do segmentation of lesions for facilitating triage. And you would assume, okay, so if we train a state-of-the-art model with a large data set and this will generalize well. So we took the NN unit, which is in all of the challenges that were done in this problem was state-of-the-art. And this is basically the performance that we had on the in-distribution test data. So we see we have a DICE, which is a segmentation score of around 73%. However, we saw that when we created even some minimal shifts, these were synthetically generated shifts, such as artifact shifts and affine shifts, the performance falls a lot. And this even happens when, say, we take a different data set, which is supposed to represent the same task. So these two data sets were open source data sets where they were segmenting the same type of lesions from, these were all chest CTs. So you would expect, okay, the system should generalize well, but it doesn't. We see a very marked fall in performance. And of course, this even happens when we are trying to segment lesions. So this is an in-house data set that we have from patients with COVID versus other types of pneumonia. So yeah, these are just some of the shifts that you see occur when, say, CT, MRI images, and you see how they impact the performance so much that a system that could be helpful initially completely stops being so. And this is difficult because it's not immediately easy to recognize when the system is doing something incorrectly, even though you could say, okay, with segmentations, we have the advantage that you can sometimes spot when the segmentation is incorrect. But when it comes to segmenting lesions from lungs, you can have multiple numbers of connected components. You see that the shapes are don't follow a certain pattern, so it's very difficult to see what's happening. So another factor that created this shift is that we actually had different virus variants, right? We have like the alpha, beta, and gamma variants, and these also show differences on the chest CTs. Another common example that we have of distribution shifts in medical data is, say, when we are doing prostate segmentation, which is a very, very common problem to automatically segment the prostate and trying to find prostate cancer automatically. So a big difference is that before people would use endorectal coils to acquire the images, which you can see here. This is what the coil looks like in an MRI, and this stopped being the case. So that also completely causes the system to fail. So these are just some of the shifts that we need to be able to detect in the open world. And again, like no coil. So yeah, basically there are many techniques that we can use to try to detect these shifts. I would say the three more common groups are auto-distribution detection, so trying to detect from the images some shift in what was our training data. We can also use uncertainty estimation methods such as deep ensembles, different kinds of ensembling methods, MC dropout, etc. And with these sort of domain-specific problems, we do have the advantage that sometimes we can define some sort of metrics that tell us when a prediction should not be trusted. And I'm just going to briefly touch on this because of the time. For instance, here we had the situation that we were a cohort of 38 different university hospitals in Germany, and we all wanted to create a federated learning system to segment these lesions. But we never had access to even test cases from all of these different institutions. So how can we monitor this system remotely? And we came up with, okay, you can actually calculate some very simple metrics to detect when the system is not functioning well. In classification, this is difficult, but in segmentation, just from looking at the mask, you can sometimes tell when something is incorrect. So in this case, we just gather some features such as, okay, here we are seeing if the intensity of the voxels that we are segmenting is unusual, that could be a sign this is an incorrect segmentation. We can also do, say, automatic segmentation of the lung, which is a problem that's very easy and works very well, and see if we are segmenting lesions outside of the lungs. We can see how these lesions that we are segmenting vary from slice to slice in the volume, just how many connected components we have. And through this, we can sort of monitor this system without ever having access to test data from different institutions. So yeah, this is one advantage that we have when looking at these domain-specific problems. Now, moving one step further, because of course we need to be able to detect these shifts, but this is not enough, right? We need a system that works well. We need models that work well over time. So we still see that the majority of machine learning research that is done is evaluated in static environments. So this means that like all of the data from the different sources is shuffled and then divided into training and testing. And of course, we know that that's often not possible. Say, for instance, in our case, we rarely can share data between different institutions. So we may say use federated learning where we keep the data in their institution and just like try to do updates on the model without ever putting the data in a centralized server. But the reality is that there are a lot of changes that happen over time because just clinical settings are dynamic. So if we just like say train a model at any point and just keep it, as these things change, as say acquisition practices, patient populations, all of these factors change, the system will deteriorate. So we need to be able to learn continuously. You may be familiar with this categorization of continual learning scenarios. So the first one is incremental domain learning. And at least in my work, how I have typically classified this is when you have images acquired by different institutions or with different scanners or with different acquisition parameters, which are still the same task. So say, for instance, here in classification, we are trying to classify if this is like a hand or a chest radiograph. Here, we are trying to segment like whether it's the background or the prostate. Then we have incremental class learning, where we just add classes over time. Excuse me. And then we have incremental task learning, where basically we have different tasks, so different problems, which are maybe related, but are not necessarily exactly the same. And in most of my research, and I still think when it comes to medical imaging, the most relevant is incremental domain learning, just because we have all of these changes in the acquisition that we are not aware of. So of course, like there are some opportunities when we are learning continuously, we could potentially achieve backwards transfer. So that means that actually by training with more data, we should be able to improve performance on past domains. But what we see most commonly is the problem of catastrophic forgetting. So as we learn with more and more data, we forget everything we learned in the past. We also should be able to have forward transfer. So basically, because we have trained the model with this data, with this past data, we can learn more easily from future samples. And that's true, but sometimes when we are trying to prevent the catastrophic forgetting, this results in a loss of plasticity of the models. So we are trying to prevent the model from changing, say, through regularization. So this results in the inability to learn new information. In general, we want to be able to adapt to different shifts. But another big problem that we may be having is that we may be incorporating failures. Why am I sort of repeating this information? Because one thing is when working in such high stakes domains, even though we want the system to work well and we want to leverage all of these opportunities, these risks are very real. And it's very difficult to have a system that has been approved, that has a direct outcome on the patients, that has a direct impact on the patient, if we don't have a very good monitoring strategy. So I'm just going to briefly go through some of the work that I have done, me and my collaborators in this, in terms of continual learning. So I think Roberto gave an introduction on regularization methods, saying, okay, so those are very popular. So these are sort of the methods where you're trying to prevent important parameters from changing too much. And there are also some sparse connectivity approaches that try to prevent this interference when learning new information. And then very, very popular are sort of rehearsal or pseudo-rehearsal methods, which I would say in practice typically work the best. When you are able to, say, store a subset of past examples and interleave those examples in new trainings, those are really the models that work best in practice. However, very often we cannot do this because of privacy constraints in our case. So sometimes you cannot store a subset of past examples. Still, one small scale study that we did where rehearsal was actually quite useful is we wanted to adapt this model, which was the total segmentator. So this is a model that is actually openly available, so you can actually use the weights for segmenting many different structures from full body CTs. And we wanted to adapt this to a pediatric population. So in this case here, you can see basically, so these are the adult samples. So this is the age of the samples from the total segmentator, and this is our data. So basically we had like much younger patients. And then basically we tried a few different simple methods, but at the end what worked quite well was so we have this first stage of training where we just train with all of this adult data. And again, so these are actually weights that are available, so we don't have to retrain that. And then what we can do is to just sort of fine tune with our pediatric data, but using a subset of the adult data. And we tried a few different subsets. And we found that using like 25% of the adult data and fine-tuning with the pediatric data led to the best results. And not only did we see an improvement on the pediatric patients, but also on the adults. So this was a case where we could basically use rehearsal because the adults were actually openly available images, so they were always available. But again, in many cases, you cannot do this. So we have to explore, say, forms of pseudo-rehearsal. So one thing that we looked at is, okay, so how about instead of saving samples, we save this source of prototypes. And what we were doing here was a sort of prototype-based segmentation using voxelmorph, which is a registration-based framework. So basically, registration is when we try to match two images together. So in this case, we were trying to match sort of the prototype to the image that we were using during inference. And because these prototypes were sort of like an average of the data that we had, we weren't actually storing previous cases, just sort of these aggregated prototypes. So this was one way of doing pseudo-rehearsal, which worked better than just like typical regularization and distillation approaches. One other alternative when doing pseudo-rehearsal, which protects data a lot, because you can say, okay, one form of pseudo-rehearsal is generative pseudo-rehearsal. So what you're doing is generating samples that look like samples you have seen in the past. And that can work if your samples are good enough. But again, with this type of data where we have very large 3D volumes, it can be difficult to generate realistic looking samples. So what we tried here was just to generate embeddings. So we were first training like a unit, which was a segmentation architecture, and then a BAE, which followed this unit training. And basically what we were trying to do here is to reconstruct these internal features. And by doing it with a variational autoencoder, we could then basically sample from this space and then sort of generate these features that mimicked previous features that we had in the past. And then what we did was basically just fine-tune the decoder, not the encoder. What one advantage that we have in this method, like when we one advantage that we have basically for free is that because we had like sort of this VAE, we could also do out of distribution detection out of the box. So we were training continuously by interleaving these generated features. And we were also using the variational autoencoder for detecting when a sample was out of distribution. And this worked very, very well. Here we were doing hippocampus segmentation, not so well with prostate segmentation. So these were just some examples of things that we can do. Now, one thing that I find very important and which I think is quite connected to the topic of this workshop is that how can we integrate then sort of the anomaly detection and out-of-distribution detection with the continual training? And then one class of methods that I really like are sort of these expansion-based methods where you augment the architecture over time. Or the most simple way of doing this are multimodal solutions, right? So you have like different models and then you decide at inference time which one to use. And one thing that we said in this paper that we presented last month, so this was a paper that we have been working on for a time, but we presented it last month, was basically it's a good idea to have sort of a baseline that is a multimodal baseline and is not treated sort of as an upper bound, but always as a baseline. And then basically we are differentiating between three different scenarios, whether this task identity is provided during inference. In this case, we can use the most appropriate model, whether it's not, but it's like say this is not used, and this is what many methods do. So they just use the last model state. But what we are saying is we can actually infer it. We can like infer which is the most appropriate model to use. And in that way, we can actually use such a multimodal solution as a baseline. And yeah, so basically this worked quite well. So this is the method that we are presenting, and you see that it's very close to the upper bound. And of course, it's not a complicated method, but it's just something that we thought was missing from all of these evaluations of continual learning methods, which were sometimes very, very sophisticated, when actually just detecting a shift in the distribution and finding the most appropriate method, the most appropriate model based on the characteristics of that image could be the best solution in many settings. So this here you can see basically the reconstructions of the autoencoder that we use to decide, okay, what is the most appropriate model state. So basically, so a sort of conclusion that came of this is that in many real-world settings, the best solution is to use such an expansion-based method. But of course, we cannot do this when we don't have rigid boundaries, right? Which is also a big problem when we are talking about anomaly detection or detecting shifts over time, that sometimes we don't have rigid boundaries between tasks. And this is sort of the most challenging scenario, where we don't have like these task identity labels, and we also don't have these rigid boundaries. So we did sort of a method that takes this into account, where basically what we propose is, okay, if what we can is just to say, so here you can consider this as like mini batches that come over time. And we were saying, okay, so say you start and you start training a model, and then you can always calculate sort of the distance in the latent space to the distribution that you had in your previous batches. And when this distance is big enough, you can initialize a new model. And you can continue doing that. And then at inference time, of course, you also calculate this distance, and the model state with the lowest distance is the one that you apply. So this is a bit of a workaround for having such a multimodal baseline when you have smooth changes between task boundaries. And again, this worked quite well. So basically, because we can always maintain plasticity without forgetting, and we are actually here, we were again doing segmentation. We are quite preserving the integrity of the segmentations. And we don't really need a lot more resources because the actual models are very small, so, and they're statically stored. So this isn't really a problem in terms of resources. So again, a very sort of simple solution that we came up with. A few other methods I won't go into detail, that we looked at sort of learning more semantically meaningful representation. We also did some work on sort of detecting confounders during learning, and how can we basically remove the effect of these confounders from the training. This was a paper that we presented recently. Yeah, and so I talked a lot about federated learning, and this is not a key aspect of this particular workshop, but we are always, especially in the medical community, we have a big focus on this federated learning. So we actually looked at, okay, what is the relationship between federated and continual learning? And we sort of think that it's a good idea to, when we're talking about the open world, not just think about continual change in settings, but also think about continual change in federated settings, where we have also multiple hospitals from which data comes from, and all of these see changes over time. And this is what we postulate in this paper, like how to build such an experimental setting, which is a bit more complicated, but also a bit more realistic in that aspect. Now, moving on to the last part of the talk. So I said, like, okay, we have, like, there are many different methods for continual learning, for anomaly detection, but there are often like very simple solutions that can help us achieve consistent and robust results. So sometimes it's not so much about a very sophisticated methodological change, but really about, okay, what is like a simple thing that actually works well and reliably. Now, there are still some challenges that we have when we want to use those solutions in clinical practice. One is actually, which is also an opportunity, we don't just have always like one image modality to look at separately. It's actually the case, like we have like many different hospitals, many different institutions, and they all keep like different multimodal data, and they keep different types of data, like EHR data, genomics, different types of radiological imaging. So how to integrate all of this is also a big problem, and a big challenge, because when you're actually diagnosing a patient and deciding how to proceed, doctors look at all of these factors jointly. When you're looking at the solutions that are now commercially available for, say, radiology, this isn't often the case. They only look at one modality. So already there you have like a bit of a problem, because you're saying, how can I use like this very simplified solution when I'm actually working with like much more complex data? There are also some practical problems in terms of there's often a lack of like evaluation standards in the medical domain. Like most of the data sets that we are using are natural images. So basically we did some work there trying to like standardize this. But one other very important point that I want to touch on is basically the regulatory aspects. And we actually saw a very significant change in the past few years, in the sense that before, every time that you would update a model, you would require recertification, say from the FDA or from a notified body in Europe, according to the medical device regulation. And this is now changing. So basically, both in the US and the European Union, there are guidelines that sort of make it possible to update models over time. And how this has changed is basically, this I can skip through, but basically the big change that we see here is that before, okay, we had some training, then we would evaluate the model, this would get approved and then deployed. And now with these new paradigms, what we can do is like outline change specifications, so sort of saying, okay, this is how I plan to collect more data over time. This is how I plan to update the model. Then this gets approved, and after that, it's possible to keep training these models, keep updating them as long as it's follow these change specifications. So this was a big, big change, and we are sort of seeing now what effects this has had in the market. Situations where this does not happen is when we have like widely different inputs, like say we are moving from like a non-contrast to a contrast examination, modifications that are not mentioned in the change specifications, or when we introduce a new intended use, or we see no benefit in the risk-benefit ratio. Okay, lastly, I want to talk a little bit about the work that we are doing in monitoring these AI tools. So we have seen in the past few years a very, very strong increase on the number of tools that are first developed, and then second also clear for clinical use. However, it's very, very common that, as I said in the beginning, we don't really have sort of rigorous prospective evaluations, like not even for retrospective evaluations do we have multi-center results. So this is a huge problem that we have right now. And as you see here, less than 10% report post-market surveillance. So we need to have like really, we need to be able to assess these tools over time, and each institution, each hospital needs to have a monitoring strategy in place, especially when the manufacturer doesn't provide that, of how can I make sure that this tool works well for my patients, and how can I over time notice if there is a deterioration in the performance. So one possibility that we came up with is these ensemble monitoring models. So one problem that we typically have also with these vendor solutions is that they're black boxes, right? Like this means that you have no access to the model weights, and you also have no access to the training data. So it's very difficult to say calculate some uncertainty metric. So in this case, for instance, we said we can actually do this ourselves. Like we can actually use models that we train in-house just for doing uncertainty quantification, right? So the model that actually makes the prediction for helping the physician is the FDA cleared model. In this case, we had a solution from Rapid AI, but we are training models in-house just for monitoring the performance. And this is what we did with like just like this ensemble of models for calculating uncertainties. And we find that this works quite well, first for doing like a first evaluation of will this tool even be meaningful for the data in our particular hospital, and then later also for monitoring changes. So yeah, in summary, for being able to deploy these solutions in a real open clinical world, we need to detect shifts in the data distribution. We need to also update models over time to keep them current. And we need to also have a very good monitoring strategy to make sure that these tools remain reliable over time. Yeah, thank you so much. This was a talk. Sorry, I went a little bit fast, but please feel free to ask questions.
From the audience. How do you use this uncertainty metrics to assess the model, how well the model works in the new version?
You mean, for instance, in this case?
Yeah.
Yeah, so basically, in this particular case, so we were using this for a model for detecting intracranial hemorrhage. And so we only had this, we could only use this vendor model for extracting predictions, right? Like we had our data and we were saying, okay, this has ICH, this does not have ICH. So what we did for monitoring is just train in-house classifiers. So these are classifiers that we can train ourselves. And then basically what we did was we were training an ensemble and then just looking at the divergence between predictions as a sort of uncertainty quantification. And this was something that at the beginning we weren't sure if it was going to work, because this is a common method for doing uncertainty quantification, right? Like you train an ensemble and you look at the divergence between predictions. but the actual training data of our models was different from the training data of the rapid AI system. But still, we saw that by doing this, we can get quite a good assessment of, we can basically filter out a lot of bad predictions that the vendor model is making. So that's how we were doing it, basically just calculating the divergence between the predictions of these different models that we were training and using that as a sort of uncertainty metric for the vendor model.
And then you provided this measure for, like, you can provide this measure to doctors so that they are more sure whether the prediction of the vendor model makes sense or not.
Exactly. So how we did it in the paper is because of some feedback, they said, okay, they would prefer a mode of interaction which was more simplified. So basically, we just provided like these three different uncertainty levels. So one of them was like the very good confidence, which is like, okay, 100% what we call EMM agreement. So all of the models of the ensemble predict the same, and this is also the same prediction that the vendor model is making, right? And then we have some similar. So this means that either like we have like less than 100% EMM agreement, or there is like disagreement between like the primary prediction of this ensemble and the vendor model. So that points to, okay, this is potentially a problematic case. And then there were and then some other cases where all of this mismatched. So this is basically what we were looking at. Like for these models training on site, do the predictions match the vendor model prediction, and do they match between themselves? Yeah, and follow-up work that I am actually working on that I didn't include in the presentation was actually doing this using foundation models, just trained with the images in the radiology reports, so that we can use this for monitoring many different tools. But that work is not published yet. Yeah. Oh, yes.
You mentioned, first of all, congratulations for your last presentation. You mentioned the comparison between continual learning and federated learning. So in federated learning, one big problem is the non-IID distribution. So do you have any problem if the data are very different from one site to another?
In federated learning?
No, I mean for the continual learning.
Oh, yeah, absolutely. I mean, it's oh, sorry. Oh no, if you have to keep on like, I don't know if you can hear me well. I will use the microphone just in case. So yeah, this was a little bit what we were doing in this work, where we try to compare the effect of, say, client drift in federated learning settings versus in continual settings. So I would say typically the types of shifts that you have in continual learning are different, because in federated learning, the shifts that you have are that you have different scanners, which is a big problem, right? Because the data is basically for a deep learning model completely different. Different acquisition parameters, and also a lot of changes in the demographic and the disease prevalence. So federated learning is sort of the setting when you have the most changes between different clients. In continual learning, you also see these changes to a certain extent, but a lot more smoothly. So say you still use the same scanners, but there are some change in the acquisition parameters, or maybe the radiographer that took the image did a little bit differently, or you see changes in the population, but over time. So I would say you just have sort of the same types of shifts, but a lot less marked.
No questions online, so I think thank you once again.
Thank you for the questions.
Please online.